Thank you.
Hi, everyone. Hello, hello. Thank you so much for joining us for our third now? Third anesthesia talk. How exciting. Can I get a quick show of hands for whose first menopause talk this is? Oh, so you and we've seen it before. Which means we must have done a good job last time. Yeah, absolutely. Absolutely. Well, thank you so much for coming. It's very exciting. Like I said, it's our third one. We're still ironing out some things such as the food arrival time. Don't stress. We will feed you very, very soon. If we do get really peckish, there are snacks just in the little nook behind you. For our on-site people, the bathrooms are just straight down the hall and to your right. For the people at home, I don't know where your bathrooms are, but I'm sure you'll find them. You'll be fine. So we've got two wonderful speakers this evening. We've got lovely Frances. Frances is our lead anesthesia nurse here at Negapause. We are so lucky to have her. She doesn't just do all of the anesthetizing, but she also trains all of our team internally as well on how to do a bloody good job of it. So it's really cool. We're so lucky to have her, and we're so glad to be able to share her with all of you. And then we've got Mel. She's all right. You're not going to talk her if I will. If you want to. Mel is one of our beautiful surgery nurses who came all the way from the UK and has such a good wealth of knowledge at such a young age and is going to be one of the superstar nurses out there. She's going to be smarter than me.
Oh,
You're already smarter than me.
definitely not.
She's a superstar. It's easy to learn. Cool. So let's kick it off. So we'll be starting with Mel, I presume.
Yes.
So we'll be picking up with Mel first. We will have a little break for dinner in between. All the people at home, you can go find your bathrooms. But we'll just have a short, maybe 10, 15-minute break. And we also just have we've got some very exciting news this week. We have been approved to give out CPD points. So everyone will get a certificate and some points that you get tonight, because we are now approved by the NABNT. The people. Those people. Yeah. And also, if you've been here before, you will know about this. We get a little gift. So we give out little lanyard bits for you to take and use. They've got some information on. Our last one was capnography. We do still have some of those if you wanted one of those. And then we have a physical exam and pre-med and sedation little cheat sheet, and we have lots of other merch for you to cruise and people tonight as well. So wonderful. Thanks everybody. Enjoy. Smell. Yay.
Oh, 1 second. There's someone.
Oh, if anyone in Teamland is not on mute, please mute yourselves. Thank you.
Cool. Welcome, guys. So I'm going to be talking about our pre-anaesthetic planning. Our pre-anaesthetic assessment. So what is our pre-anaesthetic assessment? So this is our physical exam and reading through our clinical history, and it's a general overall assessment of our patient and their history. So why do we do it? So this allows us to meet our patient, because sometimes they've only been seen by a vet before they come through our doors, to see their demeanour and get some baseline vitals for them as well. And we should read through their clinical history. So whenever a patient comes through kind of our doors, we have their history, we read through it just to see if there's anything that we didn't know about before. And it also helps us to see if they've had any previous anaesthetics, and it helps us tailor their anaesthetic plan to them. So the main components of our assessment, so we'll have 6 main components that we're going to go through tonight, and they're going to be our clinical history, clinical exam, our patient signalment, anaesthetic considerations, procedure considerations, and then their recovery considerations as well. So with our clinical history, does anyone know why we read through their clinical history? Does anyone have any ideas? Yeah, yeah, definitely. Yeah, perfect. Yeah, so we read through our patient's clinical history to ensure we know about the animal's current problems and any issues they've had in the past as well. So our main points that we're going to check are eating, drinking, urinating, defecating normally. And we also want to know when they last ate as well. So all of our patients undergoing anaesthesia need to be fasted, ideally for 6 hours prior. Have they lost any weight or gained weight, both unexpectedly? It could lead us to know if they've got any endocrine disorders or if something else is going on. Have they had any vomiting or regurgitation? If they've had any vomiting before, it's going to enable us to be able to give them something to stop them vomiting. And if they are a regurgitator, then we can give drugs to help. Can't always stop regurgitation, but at least we can help the esophagus and the stomach itself to minimize those risks. If they've had any coughing, sneezing, upper respiratory tract noises, especially in our brachycephalic patients as well, we kind of all know that they've got a whole heap of issues. It just lets us know kind of where they are on that baseline. And even like our general normal healthy patients as well, if they've suddenly developed a cough recently or they're sneezing, it might just help us tailor their plan a little bit differently. And if they're exercising normally as well, this is especially important for patients with heart disease because it could mean a decline in their heart disease and our brachycephalics as well. We know most of those pre-BOAS surgery have some degree of exercise intolerance. So it just gives us a good baseline of where to go. And then, as you said before, previous anaesthetics, we want to know how did they go, what pre-med got used, their ET tube size, if they had any complications, just makes us more prepared for if anything could happen. And what medications they're on. So for most medications they're on, they should be given either the morning of or they should have as normal. However, there is a few that we don't want them to have. So if they're on Forticor for their heart, for example, this really vasodilates them. And as we know, when they go under anesthesia and they have isoflurane, that vasodilates them even more. So check in with your vet and things before, but sometimes we'd want to miss that dose before their anesthetic. And if they're also on any certain blood pressure medications, such as like amlodipine, because that is quite vasoconstrictive, it can give us a few issues as well. And then also, if we can talk to the owner, they always know their animals best. So they'll be able to tell you if they've noticed anything different. And sometimes it's nice just to get an owner's perspective rather than a clinical perspective as well. So then we have our clinical exam. Can anyone tell me what vitals or what we might want to check on our clinical exam? Or no? Yeah, heart, yeah. Anything else? Yeah, temp, respirate. Yeah, yeah. Perfect. So first one I'm going to talk about is demeanor. So we want to know if they're bright, quiet, dull, really anxious. It's going to help us decide on how much of a pre-med we might want to give or how little of a pre-med we want to give and what drugs we might want to give as well. And then, yep, respiratory rate and their effort. I always recommend doing this as one of the first things that you do and try and do it from as far away as possible. So if the vets come in and then pop them in a kennel, let them settle. Some of them obviously don't, just to get the most accurate result. And as we know, some of our excitable dogs, they'll get very excited when they see you or they'll whine. So sometimes it's hard, but if we can try and get them as calm as possible, it's better. And then, yeah, listening to their chest. So when we're listening to their chest, we're not just wanting to listen to their heart. So it's important to listen to their heart so we can check for any murmurs or abnormal rhythms. But we do actually want to listen to their lungs as well. So this enables us to hear for any crackles, wheezing, or any muffled sounds. Sometimes that could indicate like a pneumothorax or a hemothorax, or sometimes you've just got a bit of an obese patient and it's really, really hard to hear their heart. But when we're listening to the heart, so this is just a diagram that kind of gives you an explanation on how to listen. So you want to listen on both the left and the right side of the heart, and you're going to start at the top dot. Listen, you want to listen for any crackles, wheezes. You should be able to hear some air movement, which normally sounds like a whoosh. Sometimes it's very, very quiet and you can't hear it. But sometimes if you hear like crackles, which kind of sounds like bubbling, that's kind of the stuff we don't really want to hear. And then you go through each of the spots, so each 4 spots, to listen to all 4 quadrants of the chest and the other side as well. And the more you listen, the more you know the abnormal. Like, you don't always need to know exactly what's wrong, but if you can recognize that something is not normal and then flag it to your vet, it's really important. So we have our heart rate and pulses as well. So this is checking that there's no pulse deficits. We should try and feel for our pulses. Code blue is our code blue. So hopefully they'll be okay. Heart rate and pulses, sorry. So we want to listen. So when we're listening to our heart, we should get our heart rate, and then we should be feeling their pulses at the same time as well. So this is to see if they are exactly synchronous with our heart and the pulse. So we're making sure there's no pulse deficits, and we want to see if they're are they bounding? Are they weak? And this is going to give us an indication on their like perfusion and potentially their high, like their fluid status as well. If you have a patient that has a fracture on a limb, if the patient allows, it's always sometimes good to feel that limb as well. See if they've got a good pulse in the distal part of their limb. It's warm to touch, just to make sure that everything and all of the, I can't think of the word now. It's gone out of my head, but making sure all the blood's flowing correctly and there's no issues there. So we have our mucous membrane and capillary refill time. So we want to check their colour, making sure that it's nice and pink and that their capillary refill time is normal, which is about 1 to 2 seconds. If they are pale, it could indicate an anemia or some kind of blood loss. If they're brick red, it could indicate sepsis, heat stroke, or a toxicity. We've got icteric, which is like yellow kind of gums. This could indicate a liver disease or potential issue with the liver. So we want to think about they might have issues metabolizing drugs and they could have longer recoveries. And then we've got cyanotic as well, which is obviously blue or purpley color. And we know that these patients need to have O2 supplementation, and they may need a rapid induction as well. If we've got a really tight fitting mask on them, we might just need to get an IV, induce them and intubate them. So you might see this quite often with your heat stroke brackies, where you just need to get a tube in as quick as possible. And we also want to see if they're moist or tacky as well. Sometimes if they're really hypersalivating, that's a fluid loss. If they're really dry, it could mean that they're a little bit dehydrated. And then we have our temperature. So having a baseline temperature will give us an indication on what's going on in the body. So if they're normothermic, no issues. If they're hypothermic, that could indicate an infection, stress. Sometimes our cats, if they've been on opioids for a little while, they can get a hypothermia from that. And they could also have a pyrexia of unknown origin. So it's just something to consider in our kind of planning. If a patient especially has a pyrexia of unknown origin, or they're kind of chronically hypothermic, we need to keep a really close eye on their temperature when they're asleep, because waking them up cold could actually exacerbate those symptoms. So we actually want them to stay. So if they're around 39, I know some of our cats can get really cold really, really quickly. Waking them up with a temperature below 36 can sometimes make them even more hypothermic. And then we have hypothermic as well. So they could be hypothermic if they're in shock, or sometimes you get those DAXIs that just stay cold forever and we don't know why. But it's good to pre-warm most of our patients before anesthesia, and does the patient actually have a reason to be cold? Have they been sedated for a long time? And it's easier to fix this when they're awake than when they're cold, when they're asleep, sorry. And then we have a pain score. So I always try and do a pain score before our surgeries and anything. It gives you an indication on already how painful they are, helps you to give a more appropriate pre-med, and it also gives you an indication on how they might feel under anesthesia as well, and if we can give any local blocks or CRIs. So then we have our patient signalment. So when we understand a patient signalment, it gives us even more information of the patient's needs and helps us prepare for anything. So we'll go through all of these individually, but the ones we're going to go through, if we've got their breed, species, age, morphology, weight, and their temperament. So we'll go through our age first. So we have 4 life stages in our patients' lives. Does anyone know what they are? Okay, so we have, we'll go through them individually. So we've got our neonates. So this is from birth to roughly about 8 weeks old. Then we have our pediatric patients, which are from 8 weeks to about 4 to 6 months old, depending on kind of your breed of dog. We have our adults, which again, depending on the breed, it's in dogs roughly about 6 months to 6 to 10 years, and in cats it's about 6 months to 8 to 10 years. And we have our geriatrics, so same above, between 6 and 10 years depending on their species and breed, although some say it's when they are over 80% of their predicted lifespan. So for our neonates and our pediatric patients, these patients are much more susceptible to become hypothermic, and really emphasizing on neonates here, because they all have a very big surface area to body weight ratio and they have reduced subcut fat. Especially our neonates are more reliant on warmth from their mum, that's kind of, and also the other litter mates as well. So we need to make sure that they are pre-warmed and they have lots of warming on there. The picture in the left-hand corner is actually a 5-week-old Jack Russell puppy that I've done before. He was pre-warmed in lots of bear hugger blankets before. This was him with his pre-med, blanket on top of him, bear hugger underneath him, and he stayed nice and toasty throughout his whole procedure, which was very nice. Neonates and pediatrics are also very dependent on their heart rate to maintain their blood pressure. Their so their heart rate will drive their blood pressure being increased. We do tolerate their mean arterial pressure being slightly lower, depending on which kind of vet you talk to and what paper you read. You can tolerate a mean arterial blood pressure of between 50 and 55, mainly in our kind of neonates and younger pediatrics. So with these, you might want to avoid any alpha-2 agonists due to the profound bradycardia. Their liver also isn't fully developed until 5 months of age, so they can sedate really quickly, and they all can also have a longer recovery time. And because their liver isn't fully developed, they can also become hypoglycemic very quickly, as they have small glycogen reserves. So I always recommend take a blood glucose before you pre-med, before you induce, if it's kind of in quick succession, and then check every 15 minutes or to 30, depending on how their blood glucose is trending. These patients as well, because they are so tiny and they're used to getting fed quite a lot, they are going to have a reduced fasting time. Again, depending which vets and papers you have a look at. It's a 4-hour maximum fast time. Some people will say 2, so you just need to be aware that they could regurgitate. They're also at a massive risk of fluid overload as well. So if you have a 1 kilo patient and you're flushing a drug with 5 mils of saline, that's a 5 mil per kilo fluid bolus. So it's just having that in the back of your mind that you want to use as less fluid as possible. And then our adults don't specifically have anything. It's more about everything that's going on in them in general. But our geriatrics are likely to have a lot more comorbidities. So their laryngeal reflexes can be diminished as they have reduced muscle function. A lot of them have cardiovascular changes, chronic renal changes, osteoarthritis, and kind of we always recommend to do liver or kidney function bloods just so you can get a gauge of how they're doing in that respect as well. And then we've got our species. So the main two we're going to talk about is cats and dogs. So with our cats, they're always classed as potentially having a risky intubation because they can have laryngeal spasm. So always make sure that we have our intubees ready. Because their tracheas have complete tracheal rings, you do need to be careful when you inflate your ET tube cuff. So it's very safe to use a tube with a cuff on it. You just have to be very careful when you inflate it. So you should always do a leak test, inflating the lungs, listening to if you can hear any airflow past, and then very gently inflating your balloon with air. Some papers say that you shouldn't inflate more than 3 mils of air, as that is when you're likely to get necrosis of the trachea. I think it's one of those things that's very hard to prove, but just always less is kind of best as long as you're not getting any air escaping. And they're more susceptible to hypothermia and fluid overload as well, again, because they're so small. Dogs in general don't have specific complications like cats do, however, different breeds do, which we will go on a little bit later. And just some numbers for you. So cats are more likely to have an anaesthetic death than dogs. So they say about 1 in every 419 cats will die under anaesthesia, and 1 in every 601 dogs will. So there's quite a big difference there in those numbers. Just again, something to have in the back of your mind. So then we have our breeds. So we're going to talk about brackies first, which are very common nowadays. And as we all know, they have a very high risk of upper respiratory tract obstruction, especially in the pre-medication and recovery period, as there's no secure airway. They're very big regurgitators, so they could aspirate, and they're also prone to ocular diseases such as eye ulcers, so use lots of lube. And then linking back into before, like checking if they have any exercise intolerance, snoring, have they had BOAS surgery? So if they have had BOAS surgery, it significantly reduces the risk of an anaesthetic and makes it safer for them. And then we have our herding dogs, so our collies and things like that. They have the potential to carry a gene mutation called the MDR1 mutation, and it means that they are more sensitive to certain drugs that can cross the blood-brain barrier more easily, and they are ACP and opioids as well. So both of which can cause prolonged and more sedation, and opioids can cause some increased central nervous system effects as well, such as hypoventilation. Then we have our sight hounds, so like our greyhounds. They are highly susceptible to having excessive bleeding and bruising. And again, it's really good to link back into their history. If they've had surgery before, did they have any tranexamic acid or anything? Did they have an adverse reaction to things? Were they really bruised? And they can also just have some really poor recoveries as well. These kind of dogs wake up very, very quickly, and some they've got very gangly legs, so it's always just something worth noting because we all know they like to break very easily. And then we have our cavies. These have got a really high chance of having mitral valve disease, especially at a very young age as well. So it's just something to note that we should be listening to these guys' hearts quite closely to try and pick something up soon. And then we have our boxers. So this is generally noticed in the British line of boxers, but they can have a really high sensitivity to ACP, and it causes very, very profound sedation, a lot of weakness, and marked hypotension. It affects their cardiovascular system the most. So it's just something to be aware of if you've got a boxer. Maybe go, if you need to use it, use a slightly lower dose, and then you can always give more. And then onto our cats. So we have our Maine Coons, and these are also associated with having the heart condition of HCM. And again, they can be really clinical at kind of very young ages. I think the youngest cat I've known is 1. And they can unfortunately come with all of those other issues that HCM comes with. And then our brachycephalic cat. So they have a very similar anatomy to dogs, but thankfully they don't have the higher risk of regurgitation or the long soft palate. It's mainly their nose. It's still worth being very cautious with them. And most cats are obligate nasal breathers. So if they've had a very long anaesthetic, just be very careful on recovery that the fact that they might struggle to breathe afterwards if their mouth isn't held open. And then we've got our temperament. So our aim is to keep us safe and the animals safe. So if your patient is showing any signs of being really anxious or aggressive, just IM sedate them. It minimizes their stress in practice, and our aim is to hopefully make sure that they're more comfortable coming into practice. And it's just worth noting that some stress patients may need more drugs due to the increased adrenaline and the catecholamines in the body. Then we've got our weight. So animals with our very low body condition scores are more likely to develop hypothermia and hypoglycemia because they have less glycogen stores. And then animals that have a higher body condition score are more likely to hypoventilate, become hypoxemic and hypercapnic. And this is due to their decreased cardiovascular function. A body condition score of an animal could also be related to an endocrine disorder, which we'll go on later. And again, just linking it all back to the history, which all links in together. It's just good to check these things. Then we've got our morphology. So we have patients that come in lots of shapes and sizes, especially our Daxies, Bassets, Corgis, our Munchkin cats with those lovely long bodies and very, very tiny legs, which we probably all know are really, really hard to get an IV into. They can also be a bit wriggly as well. So if they are, consider an iron pre-med. But when we do have our IVs, so we want to make use of our other areas. So use every IV spot you can kind of think of with these guys. So with our Bassets and even our Daxies, you can treat them like a rabbit and you can place one in their ear. You've also got the medial saphenous in a cat. It can be a little bit tricky to get to sometimes, but it's generally larger than their lateral saphenous. And then under anesthesia, if you lose your IV, you can use one in the tongue. There's been a paper on that recently, which is quite interesting. And then this is one in the ear as well. And you've also got the dorsal pedal vein, and you've also got the carpi vein as well. Sometimes, especially I've seen it in corgis and some Bassets, if you shave kind of right across their carpi and kind of bend their carpi down, they have a lovely vein, which just gives you something extra to poke. So now, by knowing all of the information we've just gathered, we can then fill out our anaesthetic form. So everyone's will look slightly different, but we'll have all of their patient signalment, any of their big histories, any blood works that we've done recently, and then their baseline values as well. And then we have our ASA classification. So our ASA classification is an anaesthetic risk based on their physical health before the procedure. It's not an indicator of patient outcome, and it doesn't consider the procedure that the patient is having, but it gives us more time to it enables us to plan a little bit more before they're anaesthetized based on what is wrong with them. And the biggest one I kind of was very shocked about when I was really looking into ASAs is actually brachycephalic breeds with mild respiratory and GI signs are automatically classed as a 3. So they're already classed as quite sick before we've even anaesthetized them. And then if they've got moderate signs, then they are a grade 4. And then other things as well to note, like with grade 3, for example, anything with like cardiac arrhythmias that were controlled and dehydration as well, which might be a big one that you see. And if any of these are an emergency, they're not technically always classed as an ASA 5. It depends on what they're in for, but you can add an E onto that as well, just as a differential when you're looking back through cases. So then we're going to look at their presenting complaint. So we've done our history, we've done our physical exam, and we know why our patient needs anaesthesia. So are they a routine case, or do they need stabilization? So if they're a routine, think about our common complications before the anaesthetic. So one thing that I once learnt was the 3 H's. So hypothermia, hypotension, and hypoventilation. Those 3 things are going to happen with every single anaesthetic that you ever do. So they're always going to be on there, plus nociception. So they're the things you're going to have. But then if it's a routine case on a brachycephalic, you'll add in things like regurgitation, aspiration, airway obstruction, and things like that. And if your patient does need stabilization, I would stop and think about anything that needs to be stabilized before your patient is anesthetized. So if it's something like they are hypovolemic and they need fluids, give them a fluid bolus and make sure their blood pressure is a bit more stable, if they're less tachycardic. If they're anemic, consider if they need a blood transfusion, if they've got a bleed. Coagulopathies, do they need some tranexamic acid? Any electrolyte abnormalities, if you've got a cat that's got a really high potassium because of a blocked bladder, see if you can get that potassium down before. And any cardiac arrhythmias as well, if they've got in VTAC or anything like that. It's so much easier to treat those when they're awake rather than when they're asleep. And then we've got some pre-existing diseases we're going to go over. So the main ones we're going to cover are cardiac disease, renal disease, endocrine disease. So we'll cover quite a few endocrine diseases in that. Liver disease, neurological disease, gastrointestinal disease, and orthopedic disease. So with our cardiac disease, it's always important to know what grade their murmur is. It can give us an indication of how bad their heart is, and although it doesn't always mean that their prognosis is worse if they have a higher grade murmur. What heart disease do they have? And have they had an echo or seen a cardiologist? So if there's an echo report, it's going to stage the disease and recommend treatment. But if they haven't had an echo, think likely diseases. So our dogs are more likely to have mitral valve disease and our cats are more likely to have HCM. And in the report, it will let you know if there's any structural changes, and this will help determine your anaesthetic plan. Are they on any medications, and when did they have their last dose? As we talked before, things like our Forticor can cause marked vasodilation, but our pemobendin, so our vetmedin, for example, will help with contractility, so that will actually help us under anaesthetic. Is it congenital? So if we've got our smaller animals, especially if they're having their routine spays and neuters, they could have PDAs, pulmonic stenosis, things like that should always get checked out, and most of them are fixable. But it can all have very profound effects on the cardiovascular system, especially under anaesthesia. And we need to consider our fluid rate as well. So they can get fluid overloaded very quickly, and especially in end-stage diseases, and then our cats as well. So then we have our renal disease. So we have 3 types of renal disease. Does anyone know what they could be? One we see all the time in older cats. Okay, so CKD, so we've got our
Sorry, I hate talking about that.
that's okay. So we have our AKI, which is our acute kidney injury, our chronic kidney disease, and then we've also got our obstructive as well. So our AKI can be brought on by toxins or sometimes even previous anaesthetics. Our CKD is generally chronic, and it's in our generally older cats and dogs. And it's just worth noting with this, they have already lost at least 70% of their renal function. So with these patients, I generally treat them very carefully, especially with their fluid, and also with their blood pressure as well. So our general blood pressure magic number is 90 systolic or a 60 mean arterial pressure. I normally increase that threshold slightly. So if you're going off systolic, I treat it at 100. And for your mean arterial pressure, I treat it at 65 to 70. It gives you a bit of a buffer, and it also just stops any of those nephrons losing any more of them, because we don't want that to happen. Try and do some recent bloods and then check their hydration status as well. Sometimes these patients can be a little bit more dehydrated. And then we've got our endocrine diseases. So does anyone know what like our most common endocrine diseases are? Anyone? Yeah, Cushing's, Addison's. Yeah, perfect. Any particular ones in cats? Anyone know? Yeah, perfect. Yeah. So we'll do hypothyroidism first. You generally more see this in dogs, but they can have a higher body condition score as they have a slower metabolism and they have reduced thermoregulation. So they could also get colder quicker as well, even though they're generally slightly bigger animals. We have our hyperthyroidism. Again, generally we see it in cats. They have a very increased heart rate generally, and they've got a high metabolic rate as well. So that causes a lower body condition score. And sometimes you find these cats might need some more drugs than what you think, just because they are just burning through them so quickly. We have our diabetes. So we need to check their blood glucose at regular intervals. So again, I check it before pre-med, and then I check it 15 minutes later, and then I'll check it every 15 to 30 minutes depending on their previous reading and their trend. They can progress into DKA quite quickly, and also recommend not using medetomidine. For these cases, it inhibits your insulin release and it can cause increased glucose in the body. On the opposite end of that, we have insulinomas. So these patients, again, I would treat them kind of similar to diabetics, but in the sense of checking their blood glucose every 15 to 30 minutes. They can get low blood glucose very quickly, especially if the mass is being handled. It's going to release, it's got the potential to release more insulin, so then their blood glucose can drop very quickly. So just keep an eye on that. Then we have our Addisons. So that's right. Yeah, of course.
What was the reason not to give medetomidine?
It inhibits insulin release, so it can cause increased glucose in the body. Yes, okay. Then we have our Addison's disease. So just check their electrolytes if you can before pre-med, just to see kind of what's going on in their body. When they get stressed in hospital, they might need a slight higher steroid dose, as it could push them into Addisonian crisis. And you shouldn't give NSAIDs for these patients because they're on steroids. Then we've got Cushing's. These dogs generally have a higher body condition score. And then, as we know, they're all generally these white fluffy things with these really big pot bellies, which then can impair their ventilation under anesthesia. So they may need to have their chest elevated, or we may even need to manually ventilate these patients. And then we have our hypercoagulable patients. So these patients are at risk of a thrombus. So we may need to check if they have that we need to check their clotting times and potentially even give them blood thinners post-operatively if we're worried. And post-operatively, they'll need to be monitored very closely to check for any signs of an embolism. So the liver is our main source for drug metabolism. And for under GA, that means that they're going to have a lot more profound sedation if they have a liver disease. And it can also mean they have a longer lasting effects as well. So with these kind of patients, we want to make sure that we're using reversible drugs, lower doses, again, because we can always give a little bit more. It's harder for us to take it away. And our main kind of liver disease, especially in our smaller patients, is they can get a liver shunt. Generally, they're congenital. You can get an acquired one, but they're not as seen. And again, we need to use lower doses, and the drugs will need to be reversible. Sometimes with these patients, all they need is an opioid and they will actually sedate very heavily, like we've given them a big dose of medetomidine. Then we have our neurological disease. So a lot of these patients, you might see that they've had seizures in the past. Induction and recovery is when they are most at their most critical time to have a seizure, especially on recovery when the body is can be quite excited. So it's always just worth having some of midazolam or diazepam handy, or even propofol, and being with them in those, being watching very carefully to make sure that they're not having one. And if we're suspected of a brain tumor as well, keep their pre-med simple, and keep, when they are asleep, keep their end tidal very low. So if their end tidal is high, it increases the pressure in the brain. We want to keep their end tidal as low as possible. So if we are worried about that, ventilate them immediately if you can. And there is this thing called the Cushing's triad, and it can be quite complicated, but just as a very basic overview, it means this will happen when the patient is about to herniate their brain. So they will have marked hypertension, they'll go bradycardic very quickly, and then they kind of almost look like they're going into sometimes an arrest kind of waveform, but they will stop breathing quite quickly. And these kind of patients is where you're going to want to have mannitol or some hypertonic saline available just to help with that brain. But it's just good things to know, that just a couple of things to look out for. Then we have our gastrointestinal disease. So we want to check that they're hydrated enough and not vomiting or having any diarrhea. Our opioids can cause ileus, especially our fentanyl CRIs, so we might want to avoid those. And then we want to avoid NSAIDs as well, because that will upset our gastrointestinal tract even more. And then our orthopedic disease. So generally with our orthopedic disease, it's on our older patients. So we want to manage their analgesia and make sure they're on as much as they're on at home, give them a nice padded table and kennel, and keep their limbs in as much of a normal position as possible. So then we have our procedure considerations. So how long is the procedure going to be? Is it going to be long or short? And do they need to have more analgesia under anaesthetic? So if we've given their pre-med and we think it's going to be longer than 4 hours, think about that we might need some more top-ups of our methadone or putting them on a CRI. Patient warming, so they're all at a hypothermia risk. So pre-warm, keep them warm, especially while we're preparing our patients for surgery too. And will they need sedation on recovery? Again, if it's been even kind of an hour or more, like 2 hours after their pre-med, they're not going to have any of those sedation drugs on board. So we might need to consider having something on recovery. If we're giving ACP for recovery, we do need to give it a little bit before, so it takes about 20 to 30 minutes to take effect, IV. So we just need to have that in the back of our minds. Is the surgery an emergency? When did they last eat? Do we need to think about if they could potentially regurg, maybe want to put in a stomach tube, hold off our esophagus for intubation? And have they been stabilized? As we said before, it's easier to have your patient stabilized before you go under anesthetic. It's just to make your life a bit easier. And are they worried that they're septic or in shock? So if we're worried about a perforated intestine or stomach, having those things in the back of your mind, just so that you know that we could be worried about kind of blood pressure, bleeding if it's a spleen, things like that, just so that we're fully prepared before we go into surgery. And is our surgery going to be painful? So most of our surgeries will be painful. So can we do a local block or put them on any CRIs as well? And then looking at the procedure that we're doing and what the main risks are, such as shock and hypotension in our GDVs, blood loss and cardiac arrhythmias and our splenectomies and things like that. And then we've got our recovery. So recovery is one of the most critical parts of anaesthesia. And before we put a patient under anaesthesia, it's important that we plan this to make sure everything goes smoothly. So 60 to 80% of anaesthetic deaths are in the recovery period. So just have a little fact there for you. I always think about if my patient needs any sedation beforehand. If they were quite anxious before, I'll always have something on hand. And if you've got trazodone in practice as well, you can give trazodone rectally. So you just take all the powder out of the capsule and mix it in some water. And you can give that rectally. I normally get the plastic part of an IV catheter and pop it up their bum. And it works really, really well. Do they have an analgesia plan? So are they going to stay on the methadone, or are they going to go down to buprenorphine and things like that? Or are they going to need a CRI because they've had much more painful procedure? Who will be recovering them? So is there a person designated to look after this patient? So you shouldn't ever leave a patient alone if intubated, and ideally someone should be with them until they are lifting their head normothermic and maintaining sternal recumbency, and their vitals should be checked for every 15 minutes or so. Do they need to be recovered next to a GA machine, or do they need any additional equipment, especially kind of our older patients? They're more likely to become hypoxic, so they might want to stay on oxygen for a little bit longer. Any patients like us spleens, you might want them to recover with an ECG. And then I've just done this on a different slide for brachycephalics. So as we know, they all come with their issues. So we want to keep brachycephalics intubated as long as possible, especially if you can see the picture in the left-hand corner. That was a bulldog, and you can just see the size of his tongue. And as we know, most of them, they've got these very squished faces, and all of that has to fit into their mouths, which can cause an obstruction. So with these patients, pull their tongues out if you can, put something in between their teeth as a gag so that it helps them breathe, and yeah, keep that tube in for as long as possible. Have re-intubation equipment close by, so that if they do obstruct, you can put a tube in very quickly. Keep the cuff inflated until the last minute in case there's any regurgitation. Check their SpO2 regularly when they're off oxygen and when they're extubated. And as I said before, equipment ready to re-intubate. So I understand that was a lot of information, but our biggest take-home points that we want is we all obviously want the best outcome for our patients. So having a good anaesthetic plan, understanding our patient and being prepared is going to help that, as well as good communication with the team, understanding the procedure, and then our post-op anaesthetic monitoring as well. Does anyone have any questions? I know that was a lot. You can ask me later as well if you don't want to stay in front of everyone. So we'll have a bit of a break now for some food. So everyone online, we're just going to take a break, and we'll see you in about 10 minutes.
Okay, welcome back to everyone online. Thank you for your patience while everyone here just grabbed a quick toilet break and some food. We're going to move on to the second presentation. So we're going to go focusing on sedations and pre-medications in the second talk. So it's going to be a bit about understanding why we use these drugs, what they do to our patients, how we can use them more effectively and safely in practice. So by the end of this talk, I really want you to feel more confident choosing and administering pre-meds, recognizing expected effects versus red flags, and understanding how your role as nurses directly impacts patient safety and anesthetic quality. So what we're going to cover today, first we'll start with why we give pre-medications, because once we understand the why, drug choices make much more sense. Then we're going to go through some key terminology, just enough so that we're all on the same page about what we're talking about, agonists, antagonists, and sedation levels. We're then going to break pre-medication down into two big components. We're going to do analgesics and sedatives and what they do when we use them and what effects you should see as nurses monitoring these patients. We're then going to look at optimizing our pre-meds, which is where our nursing role really, really shines. Things like drug choice, timing, handling environments, and patient preparations. And finally, we'll run through some practical scenarios that you may come across in practice. So before we talk about specific drugs, we just need to talk about the difference between sedations and pre-meds. So this is just kind of a little chart up here. So we've got sedation kind of refers to a clinical state, producing calmness, relaxation, and sometimes immobilization. Commonly, we use this for short procedures, diagnostics, and importantly, sedation, when we're calling it a sedation, usually doesn't progress to general anesthesia. There are different depths of sedation, so we can have mild, moderate, profound, and you'll often see this used for anxious, fractious, or painful patients when we're not planning to intubate. Pre-medication, on the other hand, refers to the drugs that we give before a general anesthetic. They're given to reduce stress, provide analgesia, improve anesthetic stability, and reduce the amount of induction and maintenance agents that we need. So you can absolutely sedate a patient without anesthetizing it, but we really shouldn't be anesthetizing a patient without pre-medication. So why do we give pre-medication? I know you're all eating right now, but does anyone want to throw out an idea of why we do pre-med? Reduce stress? Yep. Yes, smoother anesthetic. Yep. All good things. So yeah, pre-medication isn't just a routine or habit. It's very real benefits for our patients, our anesthetics, and our workflow as nurses. One of the biggest reasons, as we said, is analgesia. Giving pain relief before painful stimulus starts is far more effective than trying to catch up. Pre-meds also reduce. Yep.
Hey, we online can't see the slides. It's still on Mel's last
Oh,
page. I'm so sorry.
that's okay. Can we get Etienne in here?
IT support.
This one.
Thank you.
And maybe we need to stop sharing and start sharing again. This one, yeah. Can you see it now?
Yep, it's perfect. Thank you.
Okay, thank you. Sorry about that, guys. That is IT support. Where were we up to? Yeah, so we give the pain analgesia before the pain starts instead of trying to catch up. Pre-meds also reduce our stress and anxiety, which we also said, which can lower our catecholamine release and gives us a much more stable patient. A calmer patient is easier to handle, easier to catheterize, and easier to induce. So ultimately, it makes it all safer. We also see some improved muscle relaxation, which makes intubation and positioning easier. The pre-medication also allows us to use lower doses of induction agents, which helps maintain cardiovascular stability. From a nursing perspective, pre-meds can also make tasks like IV catheter placement and significantly easier and less stressful for the patients and the team. And finally, with good pre-medication leads to smoother, calmer recoveries, which is hugely important for our patient safety and post-op comfort. So before we dive into specific drugs, let's pause for a moment and talk about what an ideal pre-medication would look like if such drug existed. So can we think of any properties that we would want our ideal pre-med drug to do? Maybe analgesia, sedation, any others? Anxiolytic, yep. So in a perfect world, our pre-med would produce reliable, predictable sedation, provide good analgesia, have minimal effects on our cardiovascular and respiratory systems. We would also like it to be reversible and have minimal side effects. A small injection volume would be very preferable. And importantly for our nurses, not to be painful on administration. Obviously, this doesn't necessarily exist in one drug, but this is what we would, if we could design our ideal pre-med, that's what our ideal pre-med would be. So because we don't have a drug that does all of this, our pre-medication options also always involves a bit of a compromise. So pre-medication is rarely about choosing the best drug. It's about choosing the most appropriate combination of drugs for the patient, the procedure, and the clinical situation. So we're just going to do some light terminology. It won't get too heavy, but they are important words to know how drugs behave in our real patients. So can anyone tell me what an agonist is? To the receptor.
The receptor.
Yes, perfect. So an agonist is a drug that binds to a receptor and activates it, producing a response. So when we think of like a full opioid agonist, like methadone or morphine, these bind to the mu receptors and give us the analgesia. Anyone know what an antagonist is? Or would like to have a guess? I don't know specifically. So an antagonist is basically it binds to the receptor, but instead of activating it, it blocks the response. Yeah. So a good example would be naloxone.
Yes.
Yeah. So it sits on the receptor and prevents the opioids from working. Naloxone. And then things get a little bit more interesting with mixed antagonist-agonist. We will talk about one throughout this talk. So these drugs tend to activate some receptors while blocking others. They're quite fun ones. And then finally, does anyone want to have a go at what a partial agonist is? If we remember what an agonist is, anyone want to take a guess? So they bind to the receptors, but don't produce a full response. So even as the dose increases, they have a ceiling effect. So they will only produce so much of a response. And an example of this is our partial agonist, buprenorphine, which we will talk about during this talk. Just a couple more. A receptor. Where the drug binds. Yep. Yeah, that's what your hand was doing. I was right there. So it's the target site where the drug works. Different drugs act on different receptors, which is why they all produce different clinical outcomes. Efficacy. Oh, I just clicked it. I'm sorry. My bad. Efficacy. So efficacy refers to the maximum effect a drug can produce. So essentially how effective it can be no matter the dose. Some drugs will hit a ceiling where increasing the dose won't give you more of an effect. Potency. Yep, so it's how much drug is needed to produce an effect. So a highly potent drug produces a stronger effect at a very low dose, but that doesn't mean that it has better efficacy. Anxiolytics. Anti-anxiety, absolutely. So they reduce anxiety. And sedatives? Sedations, yes, cause calmness or drowsiness. Alrighty, so we'll start with analgesia with pure mu opioid receptor agonists, because these are the backbone of our perioperative pain control in small animal practice. Drugs in this group bind fully to the mu opioid receptor and give us strong, reliable analgesia, and that's the biggest strength. They do tend to produce some mild sedation, but it is important to remember that sedation is not their primary role. Analgesia is. So any sedation that we see after giving an opioid is like a bonus, not the goal. So like all opioids, they will reduce our gastrointestinal motility and they can cause dose-dependent respiratory depression. So we do need to monitor post-administration. We can often see a decrease in heart rate also, especially if we're combining with other sedatives. So it's something that we should expect and not necessarily panic about, but we always need to kind of assess in the context of the patient. So overall, these drugs give us excellent pain relief, but do require appropriate monitoring and thoughtful combinations with other drugs. We're just going to go through some of our pure mu opioids. So we have methadone. Methadone is our most commonly used opioid in small animal practice, and it is a pure mu opioid agonist. Its primary role is analgesia, and it does provide strong, reliable pain relief with some mild to moderate sedation as a secondary effect. One important feature of methadone is that it also acts on our NMDA receptors as an antagonist, which makes it particularly useful for more painful procedures and when those patients have chronic or wind-up pain. It works really well for them. From a nursing perspective, methadone is very versatile. It can be given IV, IM, or subcutaneously, and it has a duration of action around 2 to 4 hours, which makes it a really reliable pre-medication choice. Our dosing for methadone is usually between 0.2 and 0.4 mg per kg. We can also notice effects after administration of bradycardia and panting because methadone does reset our thermoregulatory set point and can change that body temperature a little bit. So usually you can give it to a dog and you'll start seeing them pant pretty soon afterwards. So these are expected opioid effects and should be monitored, but are essentially normal. Next, we have fentanyl. Does anyone use fentanyl in their practices? Yeah, perfect. So it's another pure mu opioid agonist, and it works kind of the same way as methadone, but clinically kind of behaves a little differently. It's extremely potent and has a very short duration of action, usually around 20 to 30 minutes after an IV bolus. Because of that short duration, fentanyl is rarely used as a single injection on our own, and we tend to commonly use it as a constant rate infusion, particularly for intraoperative and immediate post-operative analgesia. So our intraoperative doses, you can kind of go from around 5 to 20 microgram per kilogram per hour. Once you go over 10, you are adding to your anesthetic as well with the amount that you're giving. So you shouldn't need to use as much isoflurane and other stuff to keep them asleep because you have your fentanyl so high. But like up to 10, it's fantastic for pain relief. And then if you want to go a bit further to use less ISO, you can also do that. And then post-operatively, it's recommended to use between 3 to 5 microgram per kilogram per hour. In this setting, fentanyl provides excellent titratable pain control, but it also requires nursing vigilance, which is critical to make sure that those patients are breathing well and everything like that post-op if they've had a lot of fentanyl during the surgery. We can also have fentanyl delivered via the transdermal patches, which are great for long-term pain control, but because of their delayed onset after placing, they're really not appropriate for acute pain relief on their own. So it's more of a post-operative thing when you're weaning them off the CRIs. And then we have morphine. Does anyone still use morphine? No. So morphine is another pure mu opioid agonist, just like methadone and fentanyl, and its primary role is analgesia. Unlike methadone, morphine doesn't have the NMDA antagonism. They do behave slightly differently when you have a painful patient. Morphine is a really strong pain relief, but and has a similar duration of action to methadone, so about 2 to 4 hours. One of the reasons morphine does have a bit of a reputation is it can induce vomiting, particularly when given to preoperative non-painful patients. So if you're giving it to a patient that is not in pain, they tend to feel quite nauseous. It can also cause histamine release, especially when administered rapidly IV, which can lead to vasodilation and hypotension. So slow administration if you're ever going to use it intravenously. We can use it IV, IM, or subcut. And it also has a really valuable role in our epidural anesthesia. So we can use the little vials and the non-preservative ones in epidurals to give really good pain relief for any like hip surgeries or anything like that we're doing. Morphine, it isn't a bad drug. It's just a bit of an older drug, and it just requires appropriate patient selection, timing, and nursing monitoring. If it's what you have, it's not bad to use. Dosing wise, it's about 0.1 to 0.5 mg per kg, depending on what desired effect you're trying to get. So we're going to move on to our partial mu opioid receptor. We don't necessarily recommend these for pre-medications or necessarily sedations, but they are very good for kind of post-op pain relief once we've transitioned off our methadone or our fentanyl when our patient's a bit more comfortable. So I will just cover them quickly. But it's a partial agonist. It doesn't have the same maximal analgesic effect as the methadone or morphine. Even if we give really high doses, it has that ceiling effect. So it's a drug that has limited efficacy and it's not a dosing issue. It just can only reach so much pain relief. Clinically, buprenorphine provides mild to moderate analgesia and very minimal sedation, which can be a good or bad thing depending on the situation. If you have a post-op patient that's mildly painful, buprenorphine will do what it needs to do and it won't sedate the patient at the same time. One of its strengths is it does have a longer duration of action, so 6 to 8 hours, making it useful for ongoing pain management, and particularly in cats. Buprenorphine can be given IV or IM, and in cats it can be given transmucosally, which is extremely useful for stress reduction, and we can also use it for at-home pain relief. If your patient is on buprenorphine and is pain scoring quite high, it might not be that it has the right level of analgesia. So it might be considering maybe putting it back on a methadone or when it's next due pain relief if it is still painful. Dosing for buprenorphine is usually 0.02 mg per kg. And then our last analgesic is our butorphanol. So it's really commonly used in a lot of sedations, and it is one of our mixed agonist-antagonist. So clinically, what that means is that it's an agonist for our kappa receptor, which gives us really good sedation, which is why we tend to use it in our sedation protocols as opposed to pre-medication protocols, because it's actually an antagonist for the mu receptor. So that's really limiting its analgesic effects. So butorphanol can make patients look very calm and very settled, but it is only providing them very mild pain relief. It's often chosen because of the minimal effects on the cardiovascular and the respiratory systems, which makes it really appealing for our compromised patients. If you ever need to do a abdominal ultrasound on a patient that has heart disease, you can usually get away with giving them a bit of butorphanol, making them that little bit sleepier, but it's really safe for them, and just make the whole thing a bit nicer for them. And yeah, so we usually use it for non-painful procedures, so diagnostics. We should never really be using it for a sole analgesic for painful surgery. And dosing can kind of be between 0.2 and 0.4 mg per kg. So now we're going to look at our sedatives. So we're going to move away from our analgesic drugs. Sedatives we use to reduce anxiety, produce calmness, and make our patients easier and safer to handle. But it's important to be very clear, the majority of them do not provide analgesia on their own. In veterinary practice, sedatives broadly fall into 3 main categories. So our alpha-2 agonist, our thiophysic thiophiazanes, and benzodiazepines. Each of these drug classes do behave very differently and each have different side effect protocols, and they're suitable for different patients. So as nurses, understanding the difference between these can help us anticipate patient responses, monitor appropriately, and advocate for our patients when we don't think that the sedative is the right choice for them. So we'll start with our alpha-2 agonists. They're some of the most powerful sedatives that we use in veterinary medicine. These drugs act primarily on the central nervous system, producing profound sedation. And alpha-2 agonists also do produce some analgesic effects as well on their own. They do have some mild to moderate analgesia. One of our biggest advantages for our alpha-2s is that they are reversible. So that gives us a safety net when we're using them appropriately, that if something happens, we always know that we can reverse them. They also have excellent drug sparing effects, so we can significantly reduce the amount of induction and maintenance agents that we need for our patients under anesthetic. From a nursing perspective, the most important thing to understand is their cardiovascular effects. And these drugs do reduce heart rate and cardiac output, which we do expect. In healthy patients, respiratory effects are usually minimal, but alpha-2 agonists are usually not suitable for patients with advanced cardiac disease. When chosen appropriately, they do provide incredible sedation and handling safety, but our patient selection is everything. So they have what we call a biphasic effect on the cardiovascular system, meaning they occur in two predictable phases. So in the first phase, the drug can cause peripheral vasoconstriction, which leads to a temporary increase in blood pressure, and the body responds to that with a reflex decrease in heart rate. So after administration, you'll usually see them go quite bradycardic, but when you've got your blood pressure on, you'll see a nice blood pressure. At the same time, the alpha-2s are also acting centrally on the brain, causing a centrally mediated bradycardia. Then when we move into the second phase, the peripheral vasoconstriction begins to wear off. This happens within an hour of administration. So our vasoconstriction wears off and the blood pressure returns to normal or maybe slightly reduced, but our heart rate is going to stay low because of that central effect that the alpha-2s have had. So you may hear people say we can't give our glyco and atropine because they've had medetomidine. That's not necessarily true. We just have to wait for that initial phase of vasoconstriction to wear off, and then we are still able to treat with our glyco and our atropine if we're seeing hypotension with bradycardia, even if the patient's had medetomidine. We prefer not to reverse the medetomidine under anesthetic because that can cause an even more profound vasodilation, and then you've got more problems and it doesn't necessarily raise your heart rate that much. So we can definitely still give those drugs to increase heart rate and cardiac output and hopefully our blood pressure if you're ever in that situation. So the two alpha-2 agonists that we most commonly use in vet med are medetomidine and dexmedetomidine. Both can be used IM or IV. And the most important thing to understand is that dose is chosen based on the effect that you're aiming for, not just the drug itself. So higher doses are typically the goal when we're giving sedation, whereas lower doses are used for our pre-medication. And it also affects if we're giving it IM or IV. So if we're going to give an IM sedation, we're going to go between 10 and 20 microgram per kilogram. Pre-medication, IM will probably go 5 to 10. We just want to aid putting in that catheter and have that patient calm before we actually induce it. And then IV sedation will go 5 to 10 microgram per kilogram and pre-medication 2 to 5. So IV doses are lower than IM doses because of the faster onset of action, but also a greater predictability of what it's going to do. The duration of action is also dose dependent, meaning higher doses will going to last longer and have more pronounced effects. From a nursing perspective, it's essential to always know why a particular dose has been chosen, as that helps us anticipate depth of sedation, monitoring requirements, and the recovery of our patients. So we'll move on to our thiothiazines. So the one that we do see most commonly is acepromazine. It's like a different class of sedatives that we use, but still a sedative. Acepromazine does produce moderate dose-dependent sedation, but one of the most important things to be clear about is that it does provide zero analgesia. So we never want to be giving acepromazine on its own. One of its most defining features is that it is non-reversible. So once we give it to that patient's got it on board for the next 6 to 8 hours. We cannot reverse that. It causes peripheral vasodilation through alpha-1 antagonism, which can lead to hypotension, particularly in our hypovolemic or compromised patients. It does have some useful additional effects, though. It is a bit of an antiemetic, and it's also a bit of an antihistamine, and it has very minimal respiratory effects. So when used thoughtfully, acepromazine can be helpful, but it's really not a one-size-fits-all sedative. Looking specifically at acepromazine, it can be given IM or IV. The dose is dependent on the route of administration again, so 10 to 20 microgram per kilogram if we're giving it IM, 5 to 10 if we're giving it IV. It does have a really long onset of action, which I think Mel did talk about briefly. So if we're given an IM dose of acepromazine, it does have a 40-minute onset of action, and it really needs that 40 minutes of having that patient calm, not touching it, for the drug to work. And IV, it's a 20-minute onset of action. So it does take its time to work. If you do leave it, it does work. Again, our IV dose is lower because the effect is more immediate and predictable. One more important thing to remember is the long duration of action, so 4 to 6 hours, and it's non-reversible. So from a nursing perspective, the effects are going to persist into recovery of our patients. They may need ongoing support with thermoregulation and blood pressure. It's not fast acting, but when we can plan ahead and allow adequate time to work, it does work well. It never really produces reliable sedation in cats, so I would just avoid it in cats. Dogs, it can work. Cats, it doesn't really work that well. So just a couple of little myths. Can we use ACP in our seizure patients? Yes, we can. Acepromazine can be used in seizure patients. It doesn't lower the seizure threshold. It's a long-standing myth in the veterinary world, and it has been disproven. So we can use it in seizure patients. And Mel did talk about boxers before. Can we use it in boxers? We can. We just have to pick patients. We have to pick our boxers. So some of them can have quite a profound vasovagal response and significant bradycardia, which can lead to syncope. So if our patient in our pre-anesthetic exam already has a low resting heart rate, we're probably not going to pick it because it may be one of those boxes. Those boxes really do exist in the UK. I have not seen one in Australia. So when I worked in the UK, we avoided it like the plague because those boxes just dropped, but I haven't seen one in Australia so far. So a slow heart rate before pre-medication is a useful clue that you might want to adjust your plan and not use it. But this is where our nursing observations can make a really big difference and help out our vets. So we're going to have a quick look at our benzodiazepines. They're quite a unique group of sedatives, and they're particularly useful in our old, sick, or very young patients. They tend to produce mild sedation with excellent muscle relaxation. They're not reliable sedatives on their own in healthy adult animals. Your dog is probably going to shoot across the room if you try and only give it midazolam. So one of their biggest advantages is that they have very minimal effects on our cardiovascular and respiratory systems. It makes them a great choice for our compromised patients. Benzodiazepines are reversible, and they also have our anticonvulsant properties, which is an added benefit in certain patients. From a nursing perspective, it's important to recognize that benzodiazepine sedated patients may look calm, but still need additional drugs for restraint or analgesia. They're like more of a supportive sedative and not a heavy hitting sedative. So we have midazolam. So it's the benzodiazepine that we most commonly use in anesthesia. It produces mild sedation with good muscle relaxation, but we need to use it with other drugs as well, as it's an unreliable sedative on its own. One of our biggest advantages of midazolam is that it's water soluble, so it causes no pain on injection, making it tolerated IM or IV. It has a relatively short duration of action, usually around 1 to 1.5 hours, which makes it useful for short procedures or part of a balanced pre-med. From a nursing perspective, midazolam is especially helpful in our old sick, pediatric, or neurological patients where our cardiovascular stability is the priority. We'll then quickly talk about diazepam. It behaves quite differently to midazolam. They're both benzos, but they do behave differently. Its primary role is an anticonvulsant rather than a pre-medication or a sedative. It's lipid soluble, which means it can be really quite painful on IM injection. So we should only be giving it IV. And then it's also, as we know, really good in our emergency seizure control and can be given rectally if the seizing patient doesn't have IV access. It again is a relatively short duration of action, around 2 hours. And because of its active metabolites, its effects can be really variable between patients. So while diazepam and midazolam are in the same drug class, we tend to prefer midazolam for pre-medication and during anesthesia, and diazepam we reserve for our seizure control. So we're just going to throw in a couple of other drugs as well, which can be really helpful in pre-meds and sedations, but are technically anesthetic agents. So alfaxolone is an injectable anesthetic agent, and slightly different to everything we've talked about so far. So unlike opioids or sedatives, alfaxolone can produce unconsciousness when given intravenously, and commonly used as an induction agent. It acts on the GABA A receptor similar to benzos, but it has a much stronger effect on the consciousness. So one of the advantages of alfaxolone is its really rapid onset when given IV, so typically 30 to 60 seconds, and its short duration of action, which gives us lots of control. It can also be given IM at some higher doses to provide deep sedation, particularly in CATS or fractures patients, but dosing and patient monitoring after that is critical because they can go down quite hard, quite fast. From a nursing perspective, it's important to remember alfaxolone is a true anesthetic, not just a sedative. So our patients do require monitoring, oxygenation, and airway awareness. If you're going to use it as a sedative, I would always recommend having some tubes available just in case that patient does lose full consciousness and you need to intubate in an emergency. So like all anesthetic agents, alfaxolone does have some side effects, but most of them are dose dependent and predictable. Cardiovascularly, alfaxolone can cause a mild reaction in cardiac output. Systemic vascular resistance can be reduced as well, and our mean arterial pressure. But with alfaxolone, we do tend to see a compensatory increase in our heart rate. Respiratory depression is dose dependent, and you may see a reduced respiratory rate and tidal volume. If the alfaxolone is given rapidly IV, it can cause short periods of apnea. So we use slow titrated administration, pre-oxygenation where possible, because that's really important. Another important nursing observation is recovery behavior. So we tend to see some excitement on recovery with alfaxolone. That tends to be more common when our pre-medication has been inadequate rather than a direct problem with the alfaxolone itself. So when alfaxolone is used thoughtfully with appropriate pre-medication and monitoring, it can be a very predictable and controllable agent. And then next we have ketamine, which is a dissociative anesthetic. This means it produces a very different state to drugs like propofol or Alfax. It works on our NMDA receptors as an antagonist. Which other drug works on our NMDA receptors? Methadone, yep. So a key thing to understand is ketamine's doses ketamine's effects are dose dependent. So at lower doses, it can be used as an analgesic or a sedative adjunct. And then at higher doses, it can produce actual anesthesia. So our sedative rates, IV can be between 0.25 to 0.5 mg per kg. IM 1 to 2 mg per kg, and then we can use it as a co-induction as well, 0.5 to 1 mg per kg IV. Unlike other anesthetic agents, ketamine causes increased muscle tone, and the patients may retain protective reflexes, particularly on induction. So you may find that they still have a stiff jaw and stuff like that if you're using it in an induction setting. It also stimulates the sympathetic nervous system and can lead to increased heart rate and blood pressure. From a nursing perspective, the most important thing to recognize is that these effects are expected, not signs that something is wrong. So ketamine is a fantastic drug when used in the right context. It provides excellent analgesia, especially for chronic and neuropathic pain. So if you do get your old arthritic dogs in, they'd probably love a bit of ketamine in their pre-med. Ketamine stimulates the sympathetic nervous system, as I just mentioned, so heart rate and blood pressure increase. Can actually be really useful in some patients. In our cats that have HCM, as Mel was talking about earlier, this is something that we want to avoid because their little hearts are already working so hard, and we don't want to increase them at all. So maybe avoid in our HCM patients. As the patients often maintain reflexes during induction, it can be helpful in some cats as they tend to keep their larynx open more. So they tend to have less laryngeal spasm, just making it easier to intubate. Ketamine can have dose-dependent depressive effects on the myocardium, which become more relevant in compromised patients or at higher doses. So kind of when you're going over those 2 mg per kg, it can have quite an effect on the myocardium and can cause myocardium ischemia. So just need to be picking the right patients for those higher doses. Respiratory effects are usually minimal when ketamine is used alone, but can be more pronounced when combined with other sedatives and anesthetic agents. But it can also cause some bronchodilation. So it can be really useful in a pre-medication sedative protocol with cats that have feline asthma. So ketamine, we really need to understand what we're using it for, when we're using it. Like, think of your patient as a whole. Does it have feline asthma? Does it have HCM? If it's got HCM, we don't want to use it. If it's just a cat with just feline asthma, it can be really useful, can help them keep that their larynx open for intubation. And it works really well in dogs as well. A lot of people think that ketamine is a very cat drug. It works beautifully in dogs also. So optimizing our pre-med. So this is where we as nurses can really shine and have an impact on how our pre-medications work. So the first thing we really need to think about is our route of administration. So IV drugs obviously work faster and more predictable, all of that. IM drugs will take longer. So our expectations on how quickly our patient's going to be pre-medded does depend on the route that we've chosen. The environment that we're in also matters. A quiet, low stress, non-stimulating space gives that pre-medication the best chance to work. If there's noise, we're handling them, restraining them. This can all counteract all of the good drugs that we've just given them. Thermoregulation. So I think this is something Mel touched on as well. So it's another key factor. Cold patients don't metabolize drugs well and recover more poorly. So keeping our patients warm from the start, as soon as they've had that pre-med, their temperature will start to drop. So we should definitely, if we can, keep our patients that have had pre-medications as warm as possible. And finally, one of the hardest things to do, and I do it myself, give it time. We give those IMED pre-meds and then we go, well, what time did we give that? About 10 minutes ago. And then we try and touch our patient, they jump up. We really need to give those drugs a lot of time to work. Set a timer. I sometimes put a timer on my phone and go, no one's touching that patient for 20 minutes. We're going to give that time to work. So optimizing our pre-med is often less about changing the drugs that we're using, but just how we're managing our patients. And then where we inject and the length of needle that we use. can also have a huge difference in how well our pre-medications work. So these are just 3 different patients and an MRI of them, and it shows how much subcutaneous fat they have above their lumbar muscles in particular. So our little Shih Tzu, he's only got 5 millimeters of fat, so he's a nice skinny one. We can use any needle, we can go straight in that lumbar muscle, it'll be beautiful. Our little tubby Daki, he had 18 millimeters of fat before his lumbar muscle. So if we're using a little orange needle, it's probably not going to quite get in there. We're going to be giving it subcutaneously. And then our big juicy golden retriever, she has 36 millimeters of fat before her lumbar muscle. So we should really probably consider using a different muscle because we are not reaching it. So we don't want our IM injections to be subcutaneous if our needle's too short because our drugs are just not going to work as well. So we like to use large, well-perfused muscle groups. I don't know if anyone uses this, but the neck is a fantastic one. Love the neck. It's my favorite spot too. I don't like the legs. Sometimes you hit off the little bone and you're like, oh no. The neck is a perfect one. Alrighty. So we're just going to do a few clinical scenarios. I appreciate it's late, so we can just run through these. We've had a few long talks tonight. So we'll just try and run through these really quickly. So scenario 1, we have a healthy but anxious dog. He's 3 years old. He's very anxious. He's coming in for a dissecting surgery. What do we think we should give him as a pre-med? He is 100% getting medetomidine. What else are we going to need to give him? Some methadone. Yeah, perfect. And then would we potentially, how are we going to want to, like, after our pre-med, where are we keeping him? Dark, quiet room. And warm. Bit of calming music, maybe. Yeah, perfect. Our second scenario is an old dog with cardiac disease. He's 13 years old. He's got a heart murmur. He's on pimabendin. He's having a dental procedure. I haven't done dentals in 11 years. He's going to have a grade 3 heart murmur. And he's having teeth out. He hasn't had an echo. The owners are saying no, we don't want an echo. Just do it. So yeah, I wouldn't give Madaz first off. I wouldn't, yeah, co-induction with Madaz is perfect. So hopefully he's a gentle old soul and we can give him some methadone and he'll let us put a catheter in. Dogs with mitral valve disease actually cope quite well with low doses of ketamine. So you can give them a nice low dose of ketamine and he will, if he's not as nice and he isn't letting us put that IV in. So yeah. Probably up to 1 mg per kg IM for cardiac patients. I don't like going over kind of 1 mg per kg for our cardiac patients. Our next one is a fractious cat coming in for some imaging. So he's 5 years old, he's fear aggressive, and he needs radiographs of his front leg, elbow. Yep. Anything else? No? Wouldn't want to give him some ketamine as well?
No, it's not ketamine.
Oh, you did. Sorry. Sorry, I didn't hear you. Sorry, I didn't hear you. Yeah, ketamine, butorphanol, medetomidine. What if he's really painful on that front leg? Yeah, I would always go methadone. Always go methadone. It's not going to get you the same sedatives effects as your butorphanol, but it is a better sedative than buprenorphine. Yeah. Yep. IM sedation. Don't stress them out trying to put a catheter in if they're trying to eat you. And environment, dark, quiet, just keep half an eye on them. We've got a painful patient in hospital. He's quiet, but he's lovely. But he's middle-aged dog. He's got terrible osteoarthritis. He's quiet, minimally reactive. He's in hospital, chilling out because he's, I don't know, on fluids or something. Do we want to give him any pain relief or? Yeah. So our actual like osteoarthritis patients, like a 0.25, our anaesthetist gives them like a 0.25 mg per kg subcut dose of ketamine, and they are a lot more comfortable for it, these patients with chronic pain. So yeah, make sure that they're not just sitting in hospital on buprenorphine. If they are painful, sitting in those cages, getting up and down and out of those cages can be really hard for these old guys. So want to make sure that they are comfortable while they're in hospital. And our final one, I promise. Our pre-med didn't work. The pre-med was given IM. The patient's still looking at me 10 minutes later, our cute little cat. Give it another 10 minutes. Yep. We might have given it IM. It didn't go IM. You know, those ones, intracat.
Yeah.
We now need to give it longer. Yep. Perfect. So just some take-home points. Pre-medication and sedation, different things. Sedation is only one part of the plan. It doesn't automatically mean good pain relief. Analgesia matters. Good pain control improves as anesthetic stability, recovery quality, and overall patient welfare. Patient selection is everything. There is no perfect pre-med. The best choice depends on the patient, the procedure, and the underlying disease. And finally, most importantly, what we do matters. So nursing care is really important, from how the drug is administered to the environment, timing, monitoring, and recovery care. Nurses have an enormous impact on pre-medication and anesthesia quality and how they work. So with that, does anyone have any questions?